Tēnā koutou, tēnā koutou, tēnā koutou katoa. So thank you everyone for coming out on such a cold Taupo winter's evening, so we really appreciate that. Verd and Serona to come on stage and introduce our guest speaker, Dr. Matt Phillips. I just wanted to say just a few brief thank yous. So I wanted to say thank you to Andre, who has given up his time tonight to video the event. So thank you to Andre, and also thank you to Daryl. Daryl's business is Live to You, and Daryl's donated the photographic equipment tonight. I'd like to say thank you to Christine Rankin and David Travis from Taupo District Council, who have paid half of the rental for the Great Lakes Centre tonight. Thank you for Tamsin, who's sitting up the back and making sure that everything runs smoothly. As always, thank you to Simone and to Lee and to Dean, who are all the work behind reverse T2 Diabetes. If any of that was left up to me, nothing would actually happen. So thank you to all of them. So I'd like to invite Serona and Vern to the stage. And they will introduce Matt for us.
Kia ora tātou. Before I hand it over to Serena, I'll just open up our mic with a karakia. He ngoi tātou. E tō mātou matu i te rangi, kia tapu tō ingoa, kia tai mai tau rangatiratanga, kia me te tau, kia pai ai, ki rungi te whenua, ki rite anō ki tō te rangi. Ho mai kia mātou ai nei, he taro mō mātou mō tēnei rā. Mura mō mātou hara, me mātou hoki, e muru nei i utuhanga, e harana ki mātou. Aua hoki mātou e kawa kia whakawaia, engari whakaorangi mātou e te kingo. Nau hoki te rangatiratanga, te kaha me te kororia, ake, amine.
Good evening everyone, Talofa lava, kia ora. My name is Serena Ramika, and it's my pleasure tonight to introduce Dr. Matthew Phillips. So Matt is the lead neurologist for neurophysiology, as well as Parkinson's, Huntington's, and motor neuron disease clinics at Waikato Hospital. His passion is in metabolic neurology, applying metabolic strategies alongside standard medication to achieve optimal neurological health outcomes. Matt devotes most of his spare time to research. He was the lead investigator on 2 world-first randomized trials that involved the application of a ketogenic diet to Parkinson's and Alzheimer's patients. I have the honour of welcoming Matt tonight as he was the neurologist for my autoimmune disease, which is myasthenia gravis. More importantly, he led another world-first study, keto and fasting used as a sole therapy for terminal cancer. My terminal cancer, which is no longer terminal. Matt is not only a neurologist, he's an educator, a traveller, a researcher, a friend, and he has a great heart for people. So without further ado, please help me welcome Matthew Phillips.
All right. Thank you for that very kind introduction by Glen, Vern, and of course, Simone. So my name's Matthew Phillips. I'm a neurologist at Waikato Hospital, and today we're going to talk about Alzheimer's disease, also known as type 3 diabetes. You're going to find out why it's also known as type 3 diabetes very shortly. And this talk kind of ties into the one I gave on cancer several months ago in this very same venue. You'll see a lot of similarities if you attended that talk. So let's begin. First, we're going to define health. That's an old New Zealand stamp, where clearly they valued the importance of health back then. How do we define health today in the medical system? Well, we actually view health as synonymous with absence of disease. We all know there's more to it than that, but that's the way we actually practice if we get rid of the person's symptoms or minimize the symptoms of a particular disease, we send them home. So to do that, we tend to rely on treatments aimed at eliminating disease. And we're trying to find disease targets. For example, heart disease, So we tend to use treatments aimed at eliminating disease. And so for heart disease, for example, we try to get rid of the high cholesterol. For degenerative disorders, people are attacking certain abnormal proteins in the cells. But is health the absence of disease? Okay, so if we defined health more accurately, then we could use therapies aimed at restoring health. And if we restored health, absence of disease should just fade away. Okay? Disease should just fade away, rather. Absence of disease would be a consequence of restoring health. So what I'm trying to say is we try to treat disease in the medical system today, but what we really need to do is try to restore health rather than attack disease. Does that make sense? So how did medicine get this way, and why do we call it medicine anyways? Why am I a doctor of medicine and not a doctor of health? Well, it goes back at least 200 years. If we look at the origin of some of these old theories, there was a debate about 200 years ago between a famous French scientist named Louis Pasteur. Pasteur stated that germs, such as bacteria, were the origin of infectious disease. And he had this thing that he championed called germ theory, which is basically disease-centric view of health and disease. Germ theory says that disease is started by specific bacteria, or usually bacteria, it's a pathogen, and you have to get rid of the bacteria or pathogen to stop the disease. It sounds simple and it sounds true. Okay? Now that theory has become the paradigm for all disorders, infectious and non-infectious both. And what we try to do now is eliminate a specific disease target for each disorder. So we're looking at non-infectious disorders like the lifestyle disorders that get people today, such as heart disease and Alzheimer's and so on. We're trying to eliminate a problem. We're trying to find the magic bacteria, the thing to tap and eliminate these disorders. And it's not working, okay? It's very limited. It's not working as evidenced by the high prevalence of all these so-called lifestyle disorders. Now, Pasteur had a contemporary who championed a different theory called terrain theory. Antoine Béchamp was a French scientist as well. He was also a medical doctor. Pasteur was not. And he stated that an unbalanced terrain, which he defined as general sort of state of the body, tissues, and cells, is what allowed germs to invade and spread and produce infectious disease. So he said, if you had a weak sort of, terrain, which you could broadly translate to health, if it was weak, then you're going to be susceptible to disease. If it's strong, the disease can't take hold. So he had a health-centric view of health and disease, and he said that there's a dysfunction in the terrain, and we have to restore the terrain. And he said that the terrain is like the soil. What we should be doing is cleansing the soil, not attacking the germs. The germs are just scavengers, and they're taking advantage of weak soil, of weak health. If you have strong health, you won't get disease. And you can see that. There are people every year who do not get the flu. They just don't get it. Doesn't matter how much you expose them. There's people who will not get COVID, no matter how much you expose them. Now, unfortunately, Béchamp did not provide a restorative target. Okay, so here was Pasteur providing all these bacteria and all these disease targets to attack. Béchamp was unable to provide a target. He just said these non-specific things like get more sunlight, get more exercise, things like that. And it wasn't very specific or scientific. So consequently, he lost the debate, and his terrain theory has remained relatively unexplored. But it may be a better way to treat the lifestyle disorders that dominate the top 10 causes of death today. So let's look at those top 10 causes of death. There are 3 lifestyle disorders most responsible for death today in the West. The first one is atherosclerosis. This is so-called hardening of the arteries. It's a disease of the arteries, and it's responsible for numbers 1 in 4 heart diseases, virtually all heart disease, and a large number of the strokes. Cancer is number 2, in some countries it's number 1. And then the third one is neurodegeneration. And most of that is Alzheimer's disease. 2/3 of it is Alzheimer's disease. That's what we're going to focus on today. Now, all of these are bolstered by this other thing. It's not actually a disease, it's a constellation of disease markers called the metabolic syndrome. And the metabolic syndrome is a number of things that a person may have. In fact, many people have this. And they include a high fasting blood glucose, which basically is equivalent to type 2 diabetes. High triglycerides, which is fatty molecules in the blood. Low HDL, which is the so-called good cholesterol. You want it to be high, not low. Abdominal obesity, so obesity around the middle. And high blood pressure, fatty liver, and inflammation throughout the body. So these are the things that constitute the metabolic syndrome. And if you look at atherosclerosis, cancer, neurodegeneration, metabolic syndrome, these are the things that dominate the top 10 causes of death. These are the killers of today. So what ties them together? Well, this goes back to how I think we should be defining health. The metabolic syndrome and the lifestyle disorders are actually different manifestations of a single disease process underlain by mitochondrial dysfunction. Mitochondria are the little batteries in all our cells that produce the energy for the cells. There's hundreds of them in a typical cell. And really, metabolism is the sum of all the chemical reactions in your body. And it can be divided into two things. Anabolism, which is building molecules up, and catabolism, which is breaking them down. Okay, so anabolism would be on the left. You've got energy, small molecules being built up to make large ones. And catabolism on the right is large molecules being broken down to make energy and small molecules. Normally there's a balance. And the mitochondrial dysfunction stems from the lost metabolic balance. In today's society, there's quite a bit of science and hoo-ha behind that, but in today's society we have too much anabolism, not enough catabolism. Anabolism is exaggerated. Anabolism is growth and replication of cells. Catabolism is breaking them down for energy. And when we get catabolic, our cells tend to go into a survival and maintenance and repair mode. And what's causing this imbalance? Well, it's mainly our dietary lifestyle. And when I say that, I mean two things. So it's not just what we're eating. That's certainly one thing. We're probably having far too many processed carbohydrates. Processed carbohydrates are carbohydrates that have been changed by people. They didn't evolve in nature normally. So sugar would be your poster child. But also, too many meals throughout the day. 3 meals a day plus snacks is not normal. It is not normal. People did not evolve with that. People did not even evolve with 3 meals a day. That's not normal. Okay? We shouldn't be eating that much. It's too much. It puts our body into growth mode all the time. And this is where this imbalance is mainly coming from. Okay, so if the mitochondrial dysfunction underlies the lifestyle disorders, it logically follows that health is mainly defined by restoring the mitochondrial function, the mitochondrial metabolism. That should be the primary goal of medicine today. Not attacking different diseases. All these diseases, what I'm saying, I think they're all connected by mitochondrial dysfunction. You have to, it's not a target you're trying to eliminate, like Pasteur's approach. It's a target you're trying to restore. Béchamp didn't have the mitochondria as his target. We now have that as the target. So now we can institute his approach to restore health. How do we do that? Well, we use metabolic strategies. Two most common and applicable ones are fasting and ketogenic diets. Fasting is a voluntary abstinence from food and drink for a controlled period of time. It's not at all like starvation. Starvation is involuntary and it's uncontrolled. Fasting can be implemented in many ways, so it can be intermittent or periodic. Intermittent fasting is things like 16 and 8, which is you fast 16 hours a day, you eat 8 of those hours, or ADF, which is alternate daily fasting, so you fast one day, you eat the next, you fast the next day, so on. 5 and 2 fasting, which is popularized by Dr. Mosley, so you sort of eat normally for 5 days a week, and then 2 days a week you cut down your calories considerably. Periodic fasting is longer fast, so the intermittent fast is sort of 12 hours to 48 hours in duration. Periodic fast would be 48 hours up to, on average, about a week. They can go longer than And so you can have a prolonged fast, say 4 or 5 days, which is what Serona was using for her condition. Well, and these other things called fasting mimicking diets, FMDs, which is where a person basically takes in 30 to 50% of their normal calorie intake, and you can do that for a long time. So it's almost like calorie restriction rather than fasting. But we call it fasting. The whole idea of fasting is to create an alternate metabolic state that restores the catabolism that we so desperately need to balance the anabolism with. So you've got to balance the growth and replication with survival, maintenance, and repair. If you're growing all the time, your cells are just going to accumulate damage. You've got to oscillate between the two. You don't want to be catabolic all the time either. You run out of energy. Eventually, you need to grow new cells at some point. But we're too much anabolism in today's society. So what are some of the advantages of fasting against the top 10 disorders? Which, remember, basically atherosclerosis, cancer, neurodegeneration, and the metabolic syndrome, of which type 2 diabetes is one. Well, fasting lowers the blood glucose and insulin levels. That's got to be good for type 2 diabetes. It increases blood ketones. When you fast, your body's running low on glucose. Glucose is the primary sugar that our body uses most of the time. But when you fast, you run out of it, and your body starts making ketones from body fat. Ketones are molecules made from fat. If you fast, it comes from your body fat. If you eat a high-fat diet, it comes from fat in the food, like ketogenic fat. And the ketones are better, superior fuels compared to glucose, particularly for your brain and your muscles. They produce more energy for every bit of oxygen you breathe in, and they produce fewer free radicals, which can damage structures in the cells. Fasting also stimulates the production of very powerful and advantageous hormones, such as growth hormone. Why would growth hormone go up when you're fasting? It's to preserve your muscle. If you fast properly, you won't lose muscle. If you fast improperly, you can. If you fast properly and you time your growth hormone right, you won't lose muscle. BDNF stands for brain-derived neurotrophic factor. That's like the growth hormone for the brain. And that goes up with fasting. So fasting, when you fast, your body knows, okay, I have to preserve the things that allow me to run fast and hunt still and be intelligent about it. What's that? It's your muscle and your brain. And that's why when people fast properly, they don't lose muscle and they don't lose brain. In fact, if you do it properly, you can gain. Fasting enhances this thing called autophagy. Autophagy is an internal cell recycling process where the cells self-digest and recycle their junky old proteins and mitochondria and other things that need to be replaced. And if you don't fast, you're not going to have efficient autophagy. Fasting stimulates mitochondria renewal. So I hope you're starting to see how it can be helpful, fasting, all these different reasons against neurodegeneration like Alzheimer's. You get your brain-derived neurotrophic factor up, you get autophagy going, mitochondria being renewed. It can be helpful against the others as well. It suppresses inflammation too, which is present in all 4 of these disorders. So that's just some of the things that fasting can do. There's a second strategy called a ketogenic diet. A ketogenic diet, quite simply, is a high-fat, adequate protein, low-carbohydrate diet, and it creates a metabolic state that mimics the catabolic fasted state. It's not quite as powerful as fasting, I don't think. It's certainly a long fast, like several days, but they're pretty good. And that's a keto food pyramid there. If you want to do a keto diet properly, it's not hard. It's basically just real food. You got to remember, you've always got to remember, the food that you see in the supermarket today is not real food. Stick to the outsides of the supermarket, please. Don't go to the middle. The aisles are not real food. Anything with a label on it that says, here's how many carbohydrates and fats, and here's the ingredients, basically. It's not real. Broccoli does not need a label. Steak does not need a label. Anything with a label, consider that a warning sign. It's not real food. I don't know how many times to say it. So the keto pyramid is basically the base is vegetables, meats. For most people who eat, they like vegetables and meats. You can make the base purely, you can make the keto diet carnivore, or you can make it vegetarian. It doesn't matter, as long as it's ketogenic. It unites carnivores and vegetarians in a single common purpose, of health. Okay, so it doesn't matter which of the two it is, as long as it's ketogenic. I've had patients on both. They do fine. The middle of the pyramid is, you can have dairy, you can have low dairy or no dairy if you want. Nuts and seeds are generally a part of a good keto diet, and fruits at the top, a little bit of fruit, and berries only. I'll explain why in a bit. So with a keto diet, you're still creating the ketones, you're trying to get that good metabolic state, favors catabolism, survival, maintenance, and repair, but it's not coming from your body, it's coming from the diet. So obviously you're not going to lose nearly as much weight, and it's far more sustainable. With fasting, you have to eat at some point. So keto diets can be implemented many ways. And the newer ones are called modified ketogenic diets. There's a lot of older ones that people still talk about in the research. They're like 100 years old. It's like comparing a Model T Ford to a Tesla. It doesn't make sense. You want to talk about the Tesla. No one's going to drive a Model T Ford. We know that they got nothing compared to a new car. It's the same with the old ketogenic diets that people keep talking about that we used 50 years ago. Well, they're not relevant anymore. They're really not that relevant. So the main essential features of a ketogenic diet is simply this. You remove the sugar. That's an obvious one. Nobody evolved on high amounts of sugar, no matter where your ancestors came from. You remove the grains. Same argument. Agriculture's only been around 10,000 years. Humans have been around for 2 or 3 million years. It's an astronomical difference. Less than 1% of our evolutionary time has been spent consuming grains. We did not evolve with grains. They're not normal food. No matter breads, pastas, they're not normal food. We haven't had that much time to get used to them. And fleshy fruits, same thing. The original watermelon was this big. The original peach was about this big. And they have more fiber and less sugar. Fruit now is full of sugar and fructose in particular, which is especially nasty. So fruit is not a good guy. A lot of people think, oh, fruit is healthy. No, it's not healthy. In tiny amounts, maybe, but definitely not in the amounts people consume. Berries are accepted. Berries are mostly in the wild state. So strawberries, raspberries, blackberries, and blueberries in limited amounts is okay. Now look, some people do fine on a low-fat diet. People who tend to be a bit leaner, they're more active, Ketogenic diet is not for everyone. It's not the cure-all for everyone. Some people do well on low-fat diets. We're not anti-low-fat here. But for most people, with the lifestyle disorders we have today that are killing us, so type 2 diabetes, obesity, atherosclerosis, cancer, neurodegeneration, it's the ketogenic diet. You want to get rid of these 3 things. And you increase the fat, olive oil, coconut oils, and creams. That's it. That's the ketogenic diet. There's nothing crazy, nothing hard to understand about it. It's real food. It's actually the normal diet. The standard diet that we eat today is not the normal diet. It is the crazy diet. Okay, so ketogenic diets are very misunderstood. They are basically there to sort of mimic fasting. I think that's the main reason to have them. They put your body into a similar fasted metabolic state to fasting. So they're more like anti-diets. They're anti-diets in that they create a fasted state. That's the way I see them. So, and again, it doesn't matter if it's vegetarian, carnivore, or something in between, as long as it's ketogenic. There are also low-carb, high-fat diets out there, and ketogenic diets is really low-carb and really high-fat. It's not just kind of low-carb and kind of high-fat. A lot of people, we were talking about this earlier today, think that they've made something that's ketogenic, but if you don't actually analyze the ingredients properly, it may just be low-carb. And to be ketogenic, it has to really be producing decent amounts of ketones. A lot of people use them for weight loss, but that's mainly just a side effect. It's not the main reason to use them. The main reason to use them is to restore your mitochondria metabolism, your metabolic health. They actually improve the lipid profile. I used to hedge my bets here and say, well, they're not so bad for the cholesterol profile, and now I say flat out that they improve it because they lower triglycerides and they raise HDL, those 2 ones that are components of the metabolic syndrome. They're the most important ones. They do slightly raise the LDL, but the LDL cholesterol, the so-called bad cholesterol, it's not so much the level that's important, it's what the size of the particle is, whether they're large or small. And keto diets increase the large ones, which are not causative of heart disease. Okay, a lot of literature and evidence is supporting that assertion now. And if keto diets are done right, they are quite easy to sustain. They're not difficult to stick to. Okay, so that's the background for Alzheimer's. What is Alzheimer's? So everyone's heard of the term dementia. Dementia is symptoms, usually memory loss, but it can be other cognitive symptoms that arises from an underlying brain disorder. The dementia is not a disorder. It's just a sign. It's like someone having a heart attack gets chest pain. The dementia is like the chest pain. Okay? So you've got to figure out what's the process hurting the brain that's producing the dementia. Dementia is an urgent health priority. Over 50 million people have it worldwide. That's a big number, but the truly scary thing about the number is it's doubling every 20 years. So it'll be 100 million in 20 years, and then it keeps going if we don't change anything. Most of these people, 2/3, have Alzheimer's disease, which is basically a disorder that kills neurons. There are other kinds of dementia, vascular, Lewy body, frontotemporal, but Alzheimer's is the most common. And unfortunately, we don't have a good treatment for it. Supportive care is the mainstay of treatment, and we do desperately need new strategies. So let's look at the two main theories for Alzheimer's at the moment. They are the amyloid and tau theories. Amyloid is a protein, and tau is also a protein. Amyloid collects outside neurons, tau collects inside neurons. And many people think that excess amyloid outside the neuron is the problem that causes Alzheimer's, and many other people think excess tau inside the neuron causes Alzheimer's. How? So you've got a normal neuron here. It's a big, sort of pink, long structure there, as shown in the picture. You get these abnormal proteins that aggregate outside or inside the neurons. So the amyloid forms these things called plaques, as shown at the bottom, outside the neurons, and the tau aggregates to form these things called tangles inside the neuron. And these abnormal proteins build and build and build, and somehow they interfere with neuron function, and you get neurodegeneration, the loss or death of neurons, and then you get dementia. That's the current theory on Alzheimer's. That's been there for a few decades now, and that's the dogma, that's the paradigm. So what people are trying to do, because obviously they think the abnormal protein aggregates are causing the disease, is they try to get rid of the tangles or the plaques. Now, there are a lot of inconsistencies with this theory. I'll just mention 5 of them. Okay, the first problem is multiple triggers have been linked to Alzheimer's. Aluminum, pesticides, air pollution, electromagnetic fields, many other things. That really, it's hard to see what they have to do with the plaques or tangles. And so how can a disorder that's very consistent in how it presents with plaques and tangles be caused by so many non-specific things? So, you know, the amyloid and tau theories don't explain how a specifically defined process like Alzheimer's can be triggered by such a wide variety of non-specific triggers. The second problem is the amyloid and tau theories don't really highlight the fact there is significant mitochondrial dysfunction in Alzheimer's, which is consistently reported, along with oxidative damage, as the earliest event in the disorder. It comes before the plaques or the tangles. Now, if the plaques and tangles are causing Alzheimer's, then how is it the mitochondria are getting damaged before that? That doesn't make sense. You got to go back to the earliest change, right? So you get reduced numbers of mitochondria in this disorder. They are wacky shapes and sizes. They have broken cristae. Cristae are the little membranes inside them that produce the energy themselves. And the energy, mechanism along the cristae is called the respiratory chain. It's not breathing like you and I breathe. It's the mitochondria breathing, and that is impaired. So these mitochondria are very damaged in Alzheimer's, and this is probably the first thing that goes wrong. The second thing is, and this gets to our type 3 diabetes, the amyloid and tau theories do not explain why Alzheimer's neurons develop this type 3 diabetes. Type 3 diabetes, what is it? It's a brain-specific form of diabetes. Now, Glen is here reversing lots of type 2 diabetes in Taupo, which is wonderful. There's another kind of diabetes called type 1, which some people have, where they don't have enough insulin. Type 2 is where you have plenty of insulin, but the cells are resistant to insulin. You need the insulin to get the glucose into the cells. So if you don't have enough, the glucose doesn't get into the cells. If you are insulin resistant, like type 2 diabetes, the glucose still doesn't get into the cells, no matter how much there is, because the cells won't take it. Type 3 diabetes has features of type 1 and type 2. There's not enough insulin around the brain, and the neurons are insulin resistant. It's a double whammy. And neurons need energy. Okay? Now, if you're just relying on glucose, this is a serious problem. Okay? So, this is a serious problem. And to show it in a picture, here's your neuron. The black dots are the glucose. The little triangles are the insulin. And the green circles are the insulin receptors. That's a normal neuron. There's plenty of glucose outside and inside the cell, plenty of insulin, plenty of receptors. In Alzheimer's, you've still got lots of glucose outside the cell, but there's not enough insulin and not enough receptors, so it doesn't get into the cell. The cell is starving in the midst of plenty glucose. That's a very simple conception, but I think it does the job. So basically what you got is low glucose metabolism and low energy production in the Alzheimer's neurons. It's not the plaques and tangles that are causing the disorder. They're an effect of the cause, which is they're running out of energy. Now, if the amyloid and tau theories are correct, then a higher plaque or tangle load should actually correlate with more neuron loss and dementia, right? If you got more of these plaques and tangles, you should have more dementia. I'm hoping that at the end of this that you agree with me that the plaques and tangle theories don't really make a lot of sense. But unfortunately, there's a very poor correlation. So, in fact, by the age of 70, up to 40% of people who are cognitively totally normal have plaques. And almost all people at the age of 70 have tangles. And then you've got mild, moderate, and severely demented people will often show similar plaque loads. People with mild will have just as many plaques as the people with severe Alzheimer's. So there's not much of a correlation. If the plaques and tangles are the cause of the problem, they should be more with the more advanced disorder. And finally, there have been some randomized controlled trials, very good studies, that have inhibited or eradicated the plaques or the tangles. More looking at the plaques, the tangles, there's still more studies coming on board, but basically none of them have improved the cognitive impairment at all. So the repeatedly negative results of these trials are really difficult to reconcile with the amyloid and tau theories. If plaques and tangles are the cause of the disorder, getting rid of them should help. Doesn't help. So this leads us to a metabolic theory of Alzheimer's. And it's always good to take the main problems with a theory and use them to make a better theory, right? You want to take the weak points of something and make them the strengths of the better thing. So here's the mitochondrial metabolic theory. Mitochondria are exposed to multiple triggers, like I mentioned, the electromagnetic fields and things like head trauma and pesticides and aluminum and so on. They're all known to damage mitochondria. Okay, so it resolves that initial inconsistency. These are all things that are known to damage mitochondria. And what results after years of exposure is mitochondria damage and dysfunction, shown in that top picture. And I won't explain how, but brain insulin resistance appears after that. It's a fairly early finding in Alzheimer's, not as early as the mitochondria. I think the brain insulin resistance appears as a compensatory response, in large part, to the mitochondrial dysfunction. I don't have time to go into why. But these are the two big problems in Alzheimer's: mitochondria damage and brain insulin resistance, type 3 diabetes. So the neurons, because of those two things, are facing a serious energy crisis. They're not getting the glucose inside them, and their mitochondria are broken up, and they're not actually able to use the glucose they have to make energy. So if they don't fix this, they're going to die. The plaques and tangles aggregate as an effect of the energy crisis. Maybe the cell doesn't have enough energy to actually recycle these things properly because its autophagy is damaged and defective. Or maybe it's trying to isolate these things and just get them away from other parts of the neuron, sort of put them into inert reservoirs where they can do the least damage to the neuron, okay? But they are effects of the disorder. They're not the cause. And then you get neurodegeneration, neuron loss, and dementia. So if you look back at the beginning of that, what do you want to treat if you want to treat Alzheimer's? Do you want to treat the plaques and tangles? Or do you want to treat the mitochondria and the brain insulin resistance? We're not doing this in medicine. We're not doing it. Very few people understand Alzheimer's this way. They don't think of it this way. It's changing, but it's changing slowly. If you look at the research over hundreds or thousands of hours of reading and thinking and try to be objective, I think you have to come to the conclusion that this makes a lot more sense than the other theory. So where does this bring ketogenic diets? Okay, so let's remember what they do is they alter the metabolism of the body. They turn your body from a glucose-sucking machine into a ketone-sucking machine. You basically become a fat metabolizer more than a glucose metabolizer. So they shift the body to fat metabolism, producing ketones from fat. That produce more energy per unit oxygen and less free radicals. So first of all, they're a better fuel source than the glucose, period, even if you didn't have Alzheimer's. But one of the powerful things in Alzheimer's is they bypass the type 3 diabetes. They bypass the brain insulin resistance. Because ketone metabolism, the neurons can use them just fine. And they can get into the neuron just fine. They don't use the same transporters as glucose. There's no ketone resistance. They go straight in. You got a superior energy molecule making up for the shortfall in glucose. How about that? And ketogenic diets also enhance mitochondria health. So they enhance biogenesis, that's the creation of more, newer ones. They enhance recycling of old and crappy mitochondria, so you want to get rid of the older ones so that newer ones can come on board. And they do a lot of other things. They alter the mitochondria population dynamics, sort of their ability to divide and fuse. But basically, look at this. I mean, the ketogenic diet addresses our main metabolic problems all in one shot. It's a complicated therapy. It's a complicated disorder. So a complicated disorder, you want a complicated therapy. You don't want to just throw a single medication, especially not one that's just going to mask a symptom, which is all we do right now, by the way. So, metabolic strategies in Alzheimer's. Fasting keto diets, in theory, should restore the health of the mitochondria. The ketones, as you can see by the big red arrow, bypass the brain insulin resistance. They don't care if there's lack of insulin. They don't care how much glucose is kicking around the cell, and they don't care if the cell has few insulin receptors. The ketones don't care. They go right into the neurons and provide energy intermediates for the mitochondria. And it's very simple, really, that in theory should mitigate the neurodegeneration, of course, the symptoms being the cognition, and in Alzheimer's, it's not just cognition, it's function and quality of life and other things. So that theory is good, but what about the evidence? Okay, so until now, unfortunately, there's only been 2 clinical trials of a keto diet in people with Alzheimer's. 3 years ago, a single-arm trial examined a 12-week keto diet in 15 people. 11 people finished it. They improved their cognitive scores just a little bit, but it was significant. But without a control group, without a comparator group who's on a normal diet or some other control diet, it's really hard to say that they didn't improve because of other factors. There's this thing called the placebo effect, which is very powerful, that if someone believes they're going to get better strong enough, they actually do start to get better. And it's a real thing. So it could have been the belief that they would get better that at least partly made them better. And also, these investigators did not look at function or quality of life. You have to look at these in Alzheimer's. Why? Because when you ask people with Alzheimer's or their families, what are the most important things to you? It's not cognition. It's function, daily function, the ability to do stuff, and quality of life. Those are the 2 things that matter most to people living with dementia. There was another trial that came 2 years ago. It's still ongoing. They haven't finished it. They just published some preliminary results. It's a randomized controlled trial. But they showed that they looked at a 12-week keto diet in 14 people, so about the same number of people as the other one. The problem with this trial is they showed a mix of MCI and Alzheimer's. MCI is mild cognitive impairment. It's not the same thing as Alzheimer's, not by a mile. Alzheimer's is a very different thing. MCI sets a lot of people up for Alzheimer's, and it's a reduction in cognition, but function is fine, okay? And it's definitely not guaranteed to go to Alzheimer's. So it's very different. Now, the most adherent improvements, patients improved in memory, but the overall adherence was not very good with this particular trial. Their function did not improve, and they did not look at quality of life. Now, there have been other studies looking at case series. So there's a fellow in the States, Dr. Dale Bredesen, who's also looked at Alzheimer's quite heavily. He's got certain protocols. He's been doing case series, which is not even a single-arm trial. You have to look at an experimental design and how strong it is to determine the quality of the evidence, okay? So something like a case series where you just look at a bunch of people that you treated and publish their results versus a single-arm trial where you properly enroll people versus the best one, which is a randomized crossover design, particularly a randomized controlled trial, but particularly a randomized crossover trial. Those are the best two, where you have two groups of people and you compare one diet against another. So that's what we did in this study called Randomized Crossover Trial of a Modified Ketogenic Diet in Alzheimer's Disease, which just came out in February this year. What we wanted to do was see if a 12-week modified keto diet was well tolerated and improved. These are the three main things we looked at: cognition, function, and quality of life. We looked at all three because we knew that the daily function and quality of life were just as important, if not more important, than the cognition. And it's at that website URL if you want to have a look. Now, within a few weeks, it became the second most popular journal article published by this journal, which was Alzheimer's Research and Therapy. It's a good journal. It's the second most prestigious Alzheimer's journal. And I guess the question is, why did it become so popular so fast? So what it means is a lot of people were interested in this article. Now you got to remember, a lot of interest doesn't mean the article's good. It might not be a very good study, but people are still interested because of the subject, keto diets and Alzheimer's. That sounds pretty cool. But I'll try to convince you that the quality was good as well. So what we did, we had a strong design. It was a single phase. So we moved everyone through at once, at the same time. Most of the time in trials, they do, this person enrolls and does 12 weeks, and then a couple months later, another person enrolls and does 12 weeks, and it takes years to do the thing, right? And you've got all this other variation that could be introduced. One person did it in winter, the other did it in summer. So with this trial, we did them all at the same time to get rid of that variation. The assessors were blinded. The people, the neurologists and geriatricians that examined the cognition, function, quality of life, they did not know which diet the patients were on. And it was a 2-period randomized crossover trial at Waikato Hospital. So what does that mean? So at the beginning, we put half the people to a keto diet, half were randomized to a usual diet. The usual diet was their usual diet plus some optional low-fat, healthy eating recommendations. This would be the standard advice that we would give someone with Alzheimer's. So we measured their cognition, function, quality of life at the start, and then at week 6 and week 12. That was the first treatment period. Then we did a 10-week washout where everybody just went back to their normal diet for 10 weeks. And we were very strict on that. And then the people that did keto went down and did usual diet and vice versa. And they did a second treatment period. So what you had was everybody getting to do both diets, and then we could compare people against themselves. So that's a very powerful kind of design if you do it correctly. There are a few things you have to watch for, because you minimize a lot of statistical problems this way. So what were the diets exactly? Well, the Alzheimer's keto diet was tailored towards the disorder. And basically, it was about 60% fat by weight, which equals about 80% fat by calorie intake. Okay, you got to specify whether you're doing it by weight or calorie intake when you do these diets. And a lot of it was saturated fat. No problem with saturated fat. Really, that's been demonized far too much. Adequate amounts of protein. It had some fiber and not very much digestible carbohydrate. What did it consist of? Mainly green vegetables, meats, eggs, nuts, seeds, creams, and natural oils. Now, I did have one patient in the trial who was a full-on vegetarian. I said, that's fine. The plan was very versatile. And a couple people who had a very strong carnivore bend. No problem. Keto diets are not about carnivore or vegetarian. They're anti-diets. Remember, the whole point of a keto diet, and this is where a lot of people get confused, is to mimic fasting. They're anti-diets. They're putting you into the no diet state, no food coming in state. That's the power of them. So you don't need to argue with people about whether they're the best diet or not, because they're not really a diet. And you can do vegetarian, vegan, keto, carnivore, keto, it doesn't matter. The control diet was basically their usual diet, so very easy to follow. And that consisted of optional low-fat recipes, which were very low in fat, particularly saturated fat, and very high in fiber. Well, higher in fiber. And that was mainly green and root vegetables, meats, legumes, whole grains, and fruits. Things that people would say are healthy on a low-fat diet. Well, most people would. So we had strict randomization. Our statistician, who never met a single patient, did all the randomizing. We had the assessors fully blinded, and people were not allowed to talk about diet at all at the assessments. And you know, some people get a little bit of keto breath when they start the keto diet from the ketones in the breath. So we had little smell fragrance diffusers in all of the assessment rooms between the assessors and the patients, so they couldn't smell that even if they had a bit of keto breath. Patients monitored their own glucose and ketones using this little monitor. It's about yay big. And they monitored them every night. And that was powerful, because if the person was having trouble, they could tell me, and I could say, okay, well, maybe you need to be following the plan a little better, and the ketones will go up. And we could try and troubleshoot what exactly they were having trouble following. The assessments were quite rigorous, so we always use the same assessor, same weekday, and the same hour of the day, just to minimize time variation. Maybe a different assessor would assess them differently. We got rid of all of that to try and make this trial very robust and repeatable. And we used really good, validated, as in they've been proven to be effective in measuring different aspects of Alzheimer's, these tools to measure cognition, daily function, quality of life. Those are the acronyms. Don't worry about the acronyms, but they are all well-validated tools. A lot of people worry about the cholesterol with keto diets, so yes, we measured full cardiovascular risk factors, weight, the number one diabetes marker, HbA1c, type 2 diabetes, and bloods, lipids. Lipids means fats. And we also looked for safety data in terms of adverse effects, of course. So what did we find? Don't worry about the chart, it's a big chart. But basically, of 26 patients, 81% of them completed the keto diet, which is high compared to those other studies I showed you. Now that means 5 people didn't finish the 12 weeks, and if I was to redo the trial again, I would actually ask the patients, not just the study partners, the husbands and wives, do you want to do this keto diet? Because 4 of those 5 people never really intended to do the keto diet. They just went along. Because imagine you have a wife or husband with Alzheimer's, you're desperate to try anything because we don't have a treatment. All right, so they were in the trial more perhaps at the behest of their partners. And one person quit on day 2 because they never intended to do it. One person quit at the end of week 1 because they never really intended to do it. And the other 2 quit not long after. So those weren't really failures related to the diet. It was failure related to never was going to do it in the first place. One person withdrew from the keto diet because they got diarrhea, because they took in a bit more coconut oil than we initially planned for. And coconut oil produces diarrhea as the number 1 side effect, so they got that, and the person got a bit distressed with it. So what I'm trying to say is there was only one side effect withdrawal related to the diet. And these are elderly people with Alzheimer's disease. It doesn't get much harder than that. If they can follow the diet, anyone can follow the diet. 50% of people were excited about the diet at the end of the trial and intended to continue it as well. So it's quite feasible, I think, to do this. What about adherence? So how well did they get the ketones up? Well, if you look at the average blood ketone level, it was just shy of 1 millimole per liter, which is consistent with mild to moderate physiological ketosis. So it translates to the ketone supplying about 12 to 15% of the brain's energy requirements. It doesn't sound like a lot, but on average, the people in this trial would have been about 20-25% deficient in glucose metabolism in the brain. Now, if you're replacing half of that or more with ketones, which are a better fuel, you're going to make up for most of the shortfall. That's pretty good, right? These are insulin-resistant brains, type 3 diabetes brains. And so the ketones go in there and help out and provide the extra energy that they are so desperately craving. So this compares favorably with other studies. The other studies that I talked about got the ketones up to about 0.3 to 0.6, so maybe half of what we got them to. And so it indicates good adherence. Okay, now these charts show the clinical outcomes. Cognition is the red line, and for the keto diet is the red line, and the usual diet is the blue line, so higher is better. And cognition improved by 2.12 points. It was not quite statistically significant. And there was a couple of reasons for that. Daily function, as shown by the red line, stayed about the same, didn't change. The blue line on the usual diet, it declined. And this is what normally happens in Alzheimer's disease, is function declines relentlessly. So that was interesting because it seems that the keto diet may have stalled that process, that daily function stayed the same. Quality of life improved, as shown by the rise in the red line. And quality of life stayed about the same, maybe dipped a little bit with the usual diet, as shown by the blue line. Now, the important thing about the daily function and quality of life increases is they were statistically significant and also clinically significant, as in the change was clinically meaningful. It was obvious to people around the patient. Okay? Often you can get a statistically significant improvement, but it's not clinically meaningful, so it's kind of like, who cares? You know? But that was not the case here. So here's a summary. The blue line's what happened with the usual diet. You can see that people went down on the ketogenic diet. The first column is cognition, the ACE3. The second one is function. The third one is quality of life. You can see they stayed about the same or went up slightly for cognition and daily function, and quality of life went up. That is why people were excited about the trial, because it's only a 12-week trial, 12-week intervention, and that is an effect that's really not seen with medications. So the improvements in daily function and quality of life were clinically significant, which is powerful because these are the factors of greatest value to people with dementia. What about those cholesterol markers? So baseline weight. People lost 2.6 kilograms of weight on average. Most of these people were in the overweight category at the start of the trial. So their BMI went from 27.2 to about 26.3, still overweight at the end of the trial. What I'm trying to say is most of them were pleased with their weight loss. I think the weight loss was a good thing. The baseline HbA1c, that's the main marker for type 2 diabetes, that went down by quite a bit, almost 3 millimole per mole. And as you know here in Taupo, because you're blessed to have Glen working here, type 2 diabetes is fully reversible. And, you know, this is very consistent with a ketogenic diet. 12 weeks, this is what they do. They drop the HbA1c. In fact, we had 2 type 2 diabetics enter the study, and only one pre-diabetic patient exited the study. One person fully reversed, and one person almost reversed. What about the cholesterol markers? So triglycerides, TG, they went down. That's what happens with the keto diet. It doesn't make the cholesterol worse, it makes it better. Now, it wasn't quite statistically significant, okay, but they did go down. The baseline good cholesterol, the HDL, it went up, and that was significant, and that's well known to happen with these diets too. So how is this bad for our cholesterol? People are going to say, what about the LDL, the bad cholesterol? Yes, it went up very slightly, and that's well known. Remember, though, it's not about the LDL level, unless you're looking at, I have to say it, pharmaceutical-funded trials from the 1990s looking at statin therapy. It's more about the particle size than the LDL level, okay? We didn't measure particle size, but long story short, I'm not worried about the slight increase in the LDL cholesterol. So most of these changes were favorable. You got a slight weight decrease, you got an HbA1c improvement, a triglyceride improvement, an HDL improvement, and a very slight increase in the LDL level, which I don't think is really all that bad at all. And so most of these changes were favorable for cardiovascular risk, for heart attacks and strokes. Adverse effects. So the top adverse effects were increased irritability, increased fatigue, and muscle cramps. And these all generally improved with time. Nobody dropped out because of these side effects, not one person. And, basically this is known. Most of the side effects of a keto diet appear in the first few weeks, and then they get better with time. Medications are different. You might not get side effects for a while, but then months or years later, the side effects creep up. The diets are different. Once your body adapts to the fat, side effects go away, and in fact, you get a lot of improvements. So it suggests that the patient's acclimated to the ketogenic diet over time, which is a good thing. Last slide. I hope that I've convinced you that health is not just the absence of disease. It is restored mitochondrial metabolism. If you restore mitochondrial metabolism, I know that you will melt away the metabolic syndrome, type 2 diabetes, obesity, and so on, fatty liver disease. It gets better. For disorders like atherosclerosis, Alzheimer's, and cancer, they're far more advanced end-stage disorders. I think you can help them by restoring the mitochondria. Whether you can cure them, I don't know. That's what we're trying to find out. And you can restore the mitochondria with metabolic strategies like fasting and keto diets. These are strategies. These are therapies. It's not a diet. It's not just starving yourself. This is the way to make yourself healthy, man. It's not the 12 different medications that you'll be prescribed. It's not the way. And I'm getting ahead of myself. Second point, numerous inconsistencies show the amyloid and tau theories of Alzheimer's to be rather shaky, and yet these same inconsistencies can be used to not just be incorporated, but provide the bulwark, the foundation for a metabolic theory of Alzheimer's. People are very belief-based creatures, so we tend to believe what we've always been taught when we were younger. Low-fat diets are healthy, being the classic example for this talk. Well, maybe they're not. Some people, like I said, yes, but for most people, maybe they're not, as evidenced by the tsunami of Alzheimer's, heart disease, and cancer, and metabolic syndrome. So I think there's a much better metabolic theory of Alzheimer's that we could use to base our treatments on. Last point, just this year, the first ever randomized trial of a keto diet in Alzheimer's showed that a modified keto diet for people with Alzheimer's appeared to improve the symptoms of this terrible disorder, particularly the two factors of greatest value to patients living with dementia, which are daily function and quality of life, and that's quite exciting. I hope that medicine changes over the next few decades to incorporate these strategies more, and maybe we can actually start to finally do some good with these really tough disorders that I wouldn't wish on anyone. Thanks very much.
Now, thank you so much, Matt. Now, because most of the people in the room are on some form of low carbohydrate or ketogenic diet, you'll probably expect some awesome and astute questions. So I'm going to run around with the microphone. Now the rules are, please introduce yourself and feel free to ask any question. Remember, there are no stupid questions. And probably if you think it's a simple question, probably 50% of the people in the room are thinking the same thing. So anyone have a question? That was perfect, wasn't it?
Hi.
You have to introduce yourself.
Oh, hi. My name's Anne Stormont, and I've been doing a keto diet for a few months. Lost some weight, felt good. But people have said to me that you can't stay on it forever. So I'd like to know, is there any reason why you can't stay on a keto or slightly modified keto diet? And what do you call a modified keto diet? Sorry about all the questions.
So I think I caught two questions. The first is that people are saying that you can't stay on it. Those are people who are not on it and don't understand it.
True.
People often have opinions about things that they've heard and they just don't know. Like they've been told something, but they've never tried it. So I was the same when I finished neurology training 9 years ago. I didn't know anything about keto diets or fasting. If you asked me about them, I would have said that's foolish. I remember having this debate with someone. They sound stupid. But it's just because I didn't know anything. I didn't know any better. So don't worry about what people say, okay? If you do it, you feel better on it. They're absolutely sustainable. There are several people in here I know that have been on them religiously for years, myself included. Second question was about the modified ketogenic diet. What is that exactly, I think? Yeah, so there's the conventional ketogenic diets and the modified ketogenic diets. The conventional ones are there's four of them. There's one that's 100 years old called the classic ketogenic diet. Then there's the MCT diet, which is about 50 years old. And then there's two others, modified Atkins and LGI, low glycemic index diet that came out about 20, 30 years ago. They're all quite strict. They all involve weighing of food, except for the modified Atkins. And they have basically less flexibility than a modified one. A modified one is basically a diet that gets the ketones up any which way it can. And so it's not as restrictive, it's much more flexible, and that's what you need for people adults. These older diets are good for kids. They've been used in kids with epilepsy, mainly, who have to eat what their mother or father put on the table. But adults aren't like that. They're a little more choosy with what they eat. So you got to give adults flexibility. And some people, like a modified ketogenic diet, can be one that can be suited to any cuisine taste. So I've had patients on an Indian-style keto diet, or Southeast Asian-style keto diet, or Italian-style keto diet, or Mexican-style keto diet. And then again, you can vary the amount of vegetable and meats. You can go vegetarian, carnivore. It's all very modifiable, and that's really important because people some people like certain foods a lot more than others. So that's all a modified ketogenic diet is. It's a newer kind of keto diet that's very flexible, and it can be applied to many different situations.
Thank you, Matt. I thought I saw a hand up somewhere in here. Marielle.
Hi, Matt. My name is Marielle. I have a question regarding the use of exogenous ketones at the start of a keto diet, for instance, to mitigate those keto flu symptoms. And how do you feel about the use of those, and do you see any value in them?
Yeah, so the question is about exogenous ketones. You can buy ketones straight up and just consume those. So my feeling is that the ketones are just the tip of the iceberg in terms of the benefits of the keto diet. They have a lot of benefits, but it's much more than the ketones. You want to make your whole body go into that shift, that metabolic shift. So in the way the body producing ketones is a sign that that's happening. If you throw in your own ketones, artificial ketones, you get the ketones up, sure, but the shift may not be happening. And the shift is what matters. Shifting the body to fat metabolism, getting the mitochondria to start doing biogenesis and renewal, getting repair pathways activated to damaged cell parts that are damaged. Artificial ketones won't do that. You'll get a nice number when you read them, and that's it. You'll get some of the effects of ketones. They're better energy molecules, yes. They might bypass the brain insulin resistance, yes, but they're not going to have those deep down effects on the mitochondria, and these are mitochondrial disorders. That's what you want. So I don't use them in my patients. I've tried them myself for quite some time, years ago, decided I didn't like the taste, I didn't like the side effects when I took them high enough, and I didn't like the cost. I've designed all these diets to be affordable even if you're on the pension. We've had patients on the pension do them, so I'm not a fan. That being said, there are a lot of people, particularly in the United States, who support exogenous ketones, but a lot of those people may be getting a financial benefit out of it as well, so you got to consider that.
I'm just going to run up there. So this is also part of lifestyle medicine is exercise. So this is the demonstration of one of the other pillars of lifestyle medicine. So there's nutrition and exercise.
I'm Hilary. I'm just wondering if you've ever come across someone who can't take fats. Are there some people that just can't handle the fats that you need to have on a keto diet?
Yeah, so can some people not handle fat? Well,
or too much, the amount sort of you probably need on a keto diet.
Say, what was that last question?
Are there some people that can't handle the amount that you need on a keto diet?
Yep. So the short answer is I don't believe that. Because, so we had 2 or 3 people without a gallbladder in this trial. Without a gallbladder, how do you digest fat? Especially a keto diet. They had no problems.
Right. Yeah. So
You've also got to remember, everyone on the planet can digest huge amounts of fat. If you fast for 5 days, and every single person on the planet, their ancestors, went without food for a few days at some point in time, otherwise we wouldn't be here to talk about it. And when you are going without food for 4 or 5 days, guess what your body's running on? It's running on almost 100% fat, body fat. Whether that comes from the body or a keto diet doesn't make a difference. So there's no such thing as a person who cannot metabolize fat. There are extremely rare disorders, that being said, that people do have to be on carbohydrate diets. They are incredibly rare disorders that you almost never see as a practicing specialist. So the long story short, over 99% of people have no problems with the fat intake. Yeah. And if someone does have problems, it means that they're probably so used to high carbohydrates that it's like breaking an addiction to get into the high fat intake. It takes a bit of time, so you might feel terrible the first few days or weeks doing it, but you will.
Hi, my name is John. What kind of effect does polyunsaturated fatty acids have on Alzheimer's?
Well, so the question was about polyunsaturated fatty acids. So I'm not worried about saturated, monounsaturated, or polyunsaturated fatty acids. The source of the fat doesn't, the kind of fat doesn't matter so much to me. There may be a difference if you did proper studies looking at a saturated versus a monounsaturated versus poly, but nobody's done that study. But to me, the main kind of fat to avoid is trans fats, which are artificial fats made by people that don't exist in nature. And thankfully, we know that trans fats are bad, and most of them have been removed. Unfortunately, there's still a lot of them out there. So vegetable oils, you don't want to have those. Unfortunately, most restaurants are using that. You want to have natural oils like olive oil, coconut oil, which are, produced through natural means. And if you go to a restaurant and order olive oil, there's a good chance that they give you something that's 50% olive oil, 50% refined vegetable oil or something like that. So I don't worry too much about the fat source as long as it came from real food.
Yeah, John considers the term polyunsaturated fatty acid to be a swear word. So,
Oh, I see. There's a bit more to the question that I didn't catch.
Hi, my name is Steve Green. I've got prostate cancer. Over the last 18 months, I've been keeping records, going on and off of the ketogenic diet to see how it affects the PSA levels in particular. I don't believe that the PSA is an accurate marker, but nevertheless, I'm using it as a guide. I've seen the levels move drastically when I keep to keto rigorously. I've got a couple of questions regarding vitamin supplements when I'm fasting. I'm currently coming towards the end of a 7-day fast before going back onto keto. But should we be taking vitamin supplements while we're on like a long fast like this, or intermittent fasting while we're eating? How does that affect the actual fasting process itself? And should we be drinking things like tea and coffee while we're actually fasting without eating? And the second question I've got is, while we're back on the keto diet, how do we know that we're getting the correct supplements while we're eating? I realise that we need to go on to vegetables, pure foods and whatever, but even if you just stay with basic salads, it's my understanding that you're not getting the range of supplements that you need for a normal, healthy lifestyle.
So the people in this trial had a daily multivitamin, mainly because my dietitian insisted on it. But you don't need supplements. I'm not a fan of supplements. I don't care if someone takes them. They're not going to do any harm, probably. But they're not necessary if you have a real diet. Why would you supplement a real diet? And the evidence for supplements is very disappointing. We've tried various supplements to improve these disorders and other similar disorders to Alzheimer's that hasn't shown any effect. So I'm not a fan of supplements. I don't think you need supplements if the diet is good. What was your second question again?
Just basically about getting the right kind of a diet while you're on keto to make sure that you're covering all the vitamins and minerals that you need.
So how do you know you're covering the supplements? So one way you can do it is measuring key vitamin and mineral levels at the start to make sure you're not deficient, and then measure them periodically. That would probably be the most direct way to ensure the diet is supporting things. But I guess it's like any diet. If you mix up the foods periodically and don't rely on the same 2 or 3 foods all the time, you're probably going to get what you need. There's a few things to watch for on the keto diet, like calcium, maybe selenium. So, selenium is really powerfully found in Brazil nuts. So I do encourage eating Brazil nuts once in a while. Calcium, once in a while, having small fish that have the bones in them, like sardines or whatever, is a really great source of calcium. So there are things that you can be deficient in that you might have to watch for. But probably if I was worried about that with someone, I just measure all those things at the start, see if they're deficient, and then check them a few months later.
Sure. Okay, thanks. And regarding the intake of fluids while you're on a long-term, 7-day diet, tea, coffees, green teas.
Oh, right, tea and coffee, that was it.
Water.
Yeah. So you can do fasting different ways. You can do no water, no food, so that's like the Ramadan fasting. You can't do that for very long because you do need some water. You can do the next step up, which is a water-only fast. Then the next step up is, of course, the fluid-only fast, where you have calorie-free fluids such as black coffee and tea, in addition to water. Probably if you have enough coffee or enough tea, it raises up your stress hormones, your cortisol a bit, and that might dampen your ketones because your insulin will go up a little bit too. But I think you have to have quite a lot. I've done water-only fasting, and I've done coffee and tea fasting, and I don't see a drastic difference in the level of ketosis achieved. I think you'd have to drink quite a lot to affect them. That being said, everyone's different. I think there probably would be some people that are much more susceptible to the coffee and tea than others, and it might affect the fast considerably. The only way to do it is to check your ketones as you should be doing if you're doing these long fasts or keto diet, to make sure your ketones are in the right range.
Is there a particular time of day, if you're checking ketones just once a day, is there a best time to do it?
Well, if you want to get, I get people to check them at bedtime. Why bedtime? Because it tends to be a consistent time throughout the day, and it's the last thing they do so they don't forget to do it. That being said, you can check them in the morning. If you check them in the morning, they'll be a touch lower because people generally get a cortisol surge, the stress hormone surges around 4, 5, 6 a.m. And that's why most strokes occur at that time, because it raises your blood pressure. This cortisol surge gets your body gassed up and ready to go. And it gets your liver producing glucose to start fueling the body. And of course, when that happens, the insulin goes up and the ketones drop. So you can check morning or bedtime. If you check morning, the ketones will be a little lower. That being said, some people are different, and they tend to be higher in the morning for whatever reason. But it's a good question, Glenn. I guess I prefer bedtime just because people in the morning are often getting up and going to work and yada yada, and they might forget to measure them, and I just don't want them to forget.
With the supplements, and I guess salt is not generally considered a supplement, but I understand both you and I have had some personal experience with salt deficiency.
I like, well, I've never had personal experience with salt deficiency, but it is extremely, that's not quite true. I have had probably some mild experience with it, you're right. So there's a few tricks when you do a keto diet or fast that you have to make sure you do these things right, or you're going to feel like hell. And if you do them right, it's really not hard. You'll avoid the keto flu is just this thing that basically most of the time means you're low in water or you're low in salt. You need water and you need salt. If you're low in salt or water, you're going to have hypotension, you're going to feel dizzy, you're going to feel fatigued, you're going to have brain fog. You're going to have all these keto flu things. So you have to have adequate salt. How much salt is adequate? Teaspoon a day on average. Teaspoon a day. You measure it out. You make sure you have it. Water, to be safe, 2 liters. 1.5 to 2 liters a day. It depends how much you're exercising. Depends how big you are. So if you have those 2 things, you'll be fine. And yeah, if you're considering that supplementation, definitely you have to supplement with salt. So when I start people on the keto diet, I tell them to just double the salt in all their food, and they'll probably be good enough with doing that. If they're doing a multi-day fast, you got to have a teaspoon a day of salt. Good question.
Hello, my name's Shelley, and I've had to write this down because I'm scared it'll look like I'm after my own individual diagnosis, okay? But here's what I've written. I'm a person with a fast metabolism, and I'm always hungry. I've got digestion and reflux issues. I've got a long history of Alzheimer's in my family. What would you suggest? Would you suggest fasting or the keto diet is the most effective, and why?
Well, my answer is both. And I really think it's best to combine these metabolic strategies. And what you're trying to do is resurrect the metabolic state of survival, maintenance, and repair, and rebalance it. So you're not putting your body into growth mode all the time, which is basically the soil for diabetes, Alzheimer's, and so on. So I would recommend you just try a bit of both. You do a mild ketogenic diet, and you combine it with some mild fasting. Maybe go to 2 meals a day, 2 1-hour eating periods, and see how you feel. And if that works fine, then you can just maintain it. And if you want to go harder, you can go to 1 meal a day or increase the strength of the keto diet. I don't know that there's enough data to really give you a solid answer on that, but I think, you know, people, you should trust your body and do what feels right and what works for your lifestyle. And that's a good strategy that I try patients on, is to try a bit of both. Sorry, didn't quite hear you there.
The statistics on hereditary and Alzheimer's.
Oh, hereditary component of Alzheimer's? Yeah, so Alzheimer's, like Parkinson's, is sort of 5 to 10% hereditary. Look, it's really hard to tell. 5 to 10% genetic. So 5 to 10% of Alzheimer's is a genetic basis. The other 90% does not. Now, Alzheimer's does run in families, but you've got to think, is that because these people share the same genes or because they share the same environment? They grew up eating the same stuff. They grew up eating the same number of times per day. They grew up with the same lack of exercise. I have 2 aunts who have frontotemporal dementia. One has just died. Okay, they're sisters, obviously. They both got frontotemporal dementia, so everyone's saying, well, is it genetic? Well, no, but they both had the same BMI. They were both obese. They both had little tins of cookies ready all throughout their lives. They were Scottish aunts, so they always had some cookies and sugar. They picked at sugar and snacks throughout the day, probably 8 to 10 times a day they had snacks. They didn't do much exercise at all. So there were all these environmental things that are consistent between the 2 of them. And there were 2 other sisters, one of which was my mom, who were doing fine in their 80s. Not a lick of dementia, very different lifestyle. They moved away and had a very different diet. So I don't believe that, I think we overvalue how much genetic causes, these genes cause these things, including cancer and including heart attacks and Parkinson's and all of it. There are a few pure genetic disorders, yes, but most of them are not. They're mostly environmental. And that's powerful, because if you are saying that you get a disease, it runs in your family, if you got the gene, you're screwed. There's nothing you could do about it. But if it's environmental, and you can change, this is epigenetics. I don't know if you've heard of that. Epigenetics is how the genes, the genetic code is read, whether some genes are turned on or turned off. You can change that by what you eat, how often you fast, exercise, and so on. So I think most diseases are like that. And I think you can change the outcome. Yeah.
Hi, Matt. Peter Dredge here.
Ah, yes. Hey.
Hi. Yeah, good. For those of you who don't know me, I'm twice published author on Alzheimer's and brought my wife back from end stage, and she's, I think, about 1 in 25 million right now. And it's no secret to anyone who reads my writings that I'm pretty dark on the current pharmaceutically driven Alzheimer's medical establishment. So for someone who's up against an Alzheimer's diagnosis or a suspicion of Alzheimer's, there are a lot of dangers there. And I guess my question to you is, if someone comes to me and says, well, look, it's possibly Alzheimer's in the family, where do I go? Sounds to me like we've got 2 schools at your level of specialists, and the mitochondrial method, the metabolic model sounds to me, well, it completely gels with everything I know and the years of study I've put in, and I'm up against a whole lot of successful case studies and seeing a lot going on in that field. So what's your advice to someone who's going, well, we've got an Alzheimer's diagnosis, where do I go where I'm not in danger? Because that's the reality right now. If they go the wrong way and through the pharmaceutical model, they are in danger because there is a specific outcome and a certain outcome, which is that their loved one's going to die. So you're up with the politics of this, and it's a political question. So what would you say to these people?
Yeah, so, well, I would ask what they want to do, and do they want to try something different? And that really doesn't have strong evidence behind it yet, but it's accumulating, and it might make a difference. Or do you want to go down the usual standard of care, which leads to this outcome without question? Most people choose the former. That's why I have a number of patients on these strategies. I think the trouble, where people go wrong with these, as you mentioned, Pete, is there's a lack of support from other medical professionals and the community in general. So people say that keto diets can't be sustained, or keto diets are bad for you, and doctors say, oh, they raise your LDL, ignoring all the good changes in triglycerides and HDL and HbA1c and the weight loss and everything. Oh, but that doesn't matter. It's all about the bump in the LDL. Oh my God, I got to give you a statin. So, there's all this lack of support against it. And basically, doctors are very busy people. Everyone's busy. They don't have time to put hundreds of hours into studies and actually think about it properly. They just do what everyone else tells them to do, what you got trained to do, what you got told in medical school to do. So you're fighting a belief system. You're fighting a paradigm. And that's what I'm trying to fight too. We have a disease-centric paradigm. Alzheimer's is a disease of plaques and tangles. We need drugs to kill the plaques and tangles. It doesn't matter what you do with your diet or your exercise or whatever. If you got plaques and tangles, it's just going to get worse. So why even try? So you get into that medical road where they give you the cholinesterase inhibitors and other drugs that do basically nothing. Well, not nothing, but they don't do much. And then it's supportive care. The best treatment for Alzheimer's in this day and age, unfortunately, is supportive care from a caregiver. That's the best treatment by far. It's the gold standard of treatment. And then you go to a low-level care nursing home, and then you go to a high-level care nursing home, and then what follows is inevitable. So you're fighting a whole belief system, and I try to kindle a different belief in the person and their partner or caregiver. That's the key. Because a person that has a why can do any how. If you can institute that why into someone and make them believe it, and it has to be strong enough to resist the terrible advice from their GP, the terrible advice from the other specialist, the terrible advice from Joe Blogs on the street, and well-meaning family members who say that keto's bad for you. That's tough. So, and then you go to the supermarket. There's processed carbohydrates everywhere. There's sugar at the aisles. There's chocolate bars that try to nab you right at the end. They try and get you. So our society is set up for high-carb diets and terrible health. That's why so many people are overweight, have type 2 diabetes, and quite frankly are unhealthy and sick. How do you fight that? It's small steps, one person at a time, and you just keep going. You don't give up. You keep punching. That's all I can say. I don't know what else to say. I have the same issue, not quite on a personal level, but yeah.
Am I allowed the last question?
Of course, Glenn.
Do statins help or do they reduce or increase your chance of developing cognitive problems?
That's a big debate in the literature right now. There's a lot of studies that show that statins are associated with less dementia, and some show the opposite. Unfortunately, none of those studies is a randomized controlled interventional trial. So there's two types of trials: observational, interventional. Observational, you look at two groups of people over time, and then you see who got what disease and what were the things they did. So, those guys that got more Alzheimer's had more statins. Interventional trials, you take two groups of people, you do one change at the beginning in one of them and not the other, and you follow them. If they changed in their outcome, it had to be due to that change. So we changed to give them a keto diet and them nothing. You follow them, they got better, they didn't. Well, it had to be the keto diet because nothing else changed. But if you do an observational study, for example, you can't tell what was the cause, even though you have two things that are linked together. So, for example, people who smoke a lot get less Parkinson's. Does that mean I should recommend smoking to people with Parkinson's? No, it's just a correlation. It's not a causation because it's based on observational studies. So, all this data on statins and Alzheimer's is based on observational studies. We don't know. Maybe people with Alzheimer's take more statins because people with Alzheimer's have more type 2 diabetes and they have more heart disease, so they get prescribed statins more often, as you know. So my feeling is statins, well, I'm going to abstain on that one. I'm not sure. Yeah, but I'm not sure what the statin link is, if any. Yeah.
All right. So on behalf of Taupo and the people who are listening elsewhere, thank you so much for agreeing to talk to us again. We truly appreciate it. So I was just going to ask Vernon to come up, and we have a wee gift that Jenny Cook-Battersby, who's sitting down there but doesn't want to come up on stage to give it to you, but she's just sitting down there. It's one of her beautiful prints. And just hand over to Vernon to close.
Kia ora tātou. It's my honour to close the evening tonight with a karakia. Just before I close, just want to thank our dear friend Dr. Matt Phillips, for again sharing your very valuable time with us. We all get so much out of these evenings, and so it's just a blessing that you've come down tonight and shared all your research and extensive knowledge. So on that note, hope everybody has a good night, and I'll just close our night. Kia tātou katoa, te ata whai o tō tātou ariki o ihu karaiti, me te aroha o te ata, me te whawhinga taitanga ki te wairua tapu, ake, amene. Good night.